Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce Dr. David Holmes. He doesn't need an introduction. He was at Mayo for many years, and he taught me, as well as many other people, how to do PCI and cardiac cath. David, thank you so much. Really appreciate you spending the time with us today.
Well, it's a great pleasure and opportunity for me. And it's great to see you again after this time, because I remember our times together so well. And I remember our disappointment that you didn't come back to live in Rochester for the rest of your life. It was a huge disappointment. And you realized that, and we told you that because everybody was excited about it. But family things and all of that. But anyway, your career has been so phenomenal and you've done such great things. It's great to visit with you.
Well, thank you, David. Again, it's been such a great pleasure and an honor. And still remember all these days training by you and learning all these things. And this is all about learning. And obviously, you've done so much and you taught so many people. But maybe you want to walk us back a little bit on time. And how did you end up being interventionalist? I know you were doing some EP initially, and then you do intervention. How did this process come for you?
Sure. When I returned from the Navy, that's a long time ago. At that point in time, pacing was a red hot area. And so I then went into pacing and then became the director of pacing. And then around that period of time, then we talked about then doing HIS bundle recordings. And so I went to a course in Chicago that was a terribly frightening course where you had to sit in a great big auditorium at St. Michael's Hospital there, and one of the two doyens of electrophysiology then sat up at the front. And you then were given one of those things that was a foot long that made measurements. And you then would be called on in the audience to go to the front of the room of 200 people and diagram out on a blackboard what the electrocardiogram meant. And so we went through that. And so everybody that was going into electrophysiology went to that. It was a Katz Rosenberg symposium. So then, during those periods of time, then interventional procedures came along. Initially, diagnostic things, and at that point in time, Mayo was heavily involved with the dynamic spatial reconstructor, which was the first cardiac CT scan. And so we used to, in training, we would then take people from St. Mary's in the ambulance down and sit with them while they got a CT of their heart done. And so we then became involved with that. And then as part of that, then the catheterization laboratory was developing. And so I said, gee, this would be a wonderful place to go and to work in it. So for a while, then I was director of both electrophysiology and the cath lab for a short period of time. And then at that point in time, somebody would have tapped me on the shoulder and said, you probably can't do both. You're going to have to decide. That was during the very early days of intervention, and the sky was the limit. And we were doing things, and they were doing things at the University of Minnesota that people talked about, and it was terribly exciting. And so it was relatively easy to follow that path. And then following that path, then it continued to open up and get broader and broader and broader. And the things we were able to do to actually treat patients rather than to just take pictures about patients opened up everything. And so that then started it all.
Wonderful. And then you didn't bother, you already had done a lot of work in one area, now you're going to another area. You were always open-minded in terms of learning the new techniques and moving on that.
I think crucial part of being in the field that we're in is that there are always new things, and new things to try to get your hands around, to understand the basics for, and then how you're going to put them into your practice, and then go from there to treat patients. And so that was part of the incredibly exciting point. We went through a phase then during which time we were doing procedures, and that was a phase that people in the community weren't necessarily doing procedures. So we went as a professional organization, because at that point in time I was president of Sky. I think it was around that time. We then had to go through the business about how do you train people after they've been in practice to do some things that they didn't do in practice. That so we went through the business about doing preceptorships and how long did you have to do a procedure before you became comfortable with it, and where did you go, and how did the institution deal with that. It's of interest that that now has come back in spades. And this time, when we have so many other things that have come along since people finished their training as interventional cardiologists and are now faced with the structural things that you're doing and the chronic occlusions that you're doing, all of those sort of things that when they were in training and finished training 10 years ago, they didn't do very much of. And so it raises the issue of how do we then retrofit people if they're trained and they're interested and they're still sort of at their peaks, and they then want to get into some of the more advanced structural things. It's not something like TAVR, which most of the people with good catheter skills were able to do that, although early on it seemed like it was a far out thing. But most of the people were able to master that. It's very different than some of the complex mitral stuff and tricuspal stuff that people are coming out of practice learning how to do. And then you're trying to have to retrain people if they want to do that, if they want to take the time to do that, if they want to put in the practice to do that. That's going to, I hope, continue to be an issue, because I would hope that we will have continued technology changes that will affect the practice and allow us to treat more patients more successfully and safer and earlier during the course of their disease. And so I hope that this is an ongoing thing, that the professional societies working with the leaders in the field, such as yourself and others, are going to come up with strategies for post-training training. And that
And
will be exciting. Now, how are we going to do that? The field has been so good about bringing along some simulated technology. You've used that, and other people have done that. To the extent that the haptics are going to be good enough, that'll be a terribly important part of training. So some of the robotic procedures that we haven't done before, we'll learn how to do that in cooperation and collaboration with our surgeons who have been doing robotic things for a long time, or at least some of them have. And so I think that we will see the future being very robust and doing things that we never thought we would do. And provided that we want to become experienced with that and really provide expert care, that's going to be a great opportunity. And I foresee that we will continue in some areas to become more surgically minded, maybe more neurosurgically minded. So we're going to do stuff above the siphon. Now that's pretty exciting. To look for it, example, at embolic protection devices above the siphon. Wow. And look at different strategies for delivering drugs in different areas of the body. We should make sure that we say, this should be in our space. We'll take the time to learn it. We'll take the time to learn the science. We'll take time to learn the technology. We will then get comfortable with the field and build our practices about that. I'm not sure It's not necessarily to splinter the practice, although along those lines, there will be people that will specialize in one thing or another. And that will allow those groups to more expertly use the new technology that comes along and is part of the field. And that's what has made the field so wildly exciting and forward looking. I think at that point in time that we say, well, we've learned everything we need to learn. We can treat everything that we need to treat. Gee, then that would be time to maybe look for another
Another specialty.
or another part of your life or something. So those would be my thoughts about where we should and hopefully will want to and can go. And it will involve expert teaching with either courses, which are tremendously important. Clearly, the courses on chronic total occlusion, courses on mitral valve things are still incredibly important. And I think they will become more important, and they will then incorporate more simulation that will allow us to actually feel what it's like to do the procedures before we do them.
Mhm. Now, in terms of technology will be there, as you say, the teaching tools, the simulation will be there. But how about the mindset? Do you think everyone is ready to embrace this and relearn and reinvent himself or herself down the line? Or is it just a few people who have this mindset?
I would I think that that's an incredibly important question that raises a lot of issues. I don't think anybody should be in the position of saying, I need to do something along these lines to preserve my practice. I don't think we should ever be in that mindset or take that approach. I think that if we are faced with, number one, recognizing unmet patient needs, taking care of patients, deciding if there are technologies that we can use to meet those unmet clinical needs, I think as a field, we're going to be okay. Not everybody's going to want to do that. There will be some people for a variety of reasons, either because they want to do more teaching or writing, or they want to do some more administrative work. That's fine. There will be some that don't necessarily have that burning desire to broaden the field, to have there be more approaches to those needs that we now think about that we used to think we knew all about, but we didn't. So I think there are going to always be people, and we want to encourage the growth of those people. Training communities need to do that. Those people that want to push the envelope, not without thinking, but push it having understood the issues involved. And those are the people that, number one, we should train for the future. And those are the people that, number two, if they then are in a setting where they want to move to explore those things, then we should make sure that there are opportunities that are realistic for them, for each of them, to explore those new things. Not everybody's going to want to do that. Not everybody may have the technical expertise or the equipment to do that. So it's a little bit like electrophysiology in that regard. When electrophysiology went from doing His bundle recording, where you could make a thing and measure the intervals, and that was sort of fun, unless you did it 1,000 times, and then it wasn't so much fun. When it moved then to the 3-dimensional and 4-dimensional things, not everybody was comfortable with that, nor did everybody need to do that. And some of the very complex stuff, then other people in the field could do. And some of the more straightforward things, whether that be to measure conduction intervals, which are still important, or to do pacing devices, and there's such a great number of new kind of pacing devices. That's perfect. There's lots to do in that area. not everybody's going to be comfortable with the most wide spread 3 and 4 dimensional stuff that some fields, either in electrophysiology or in invasive cardiology, are going to be familiar with. There will be some people, for example, the thought of going above the siphon would bring sweat to their forehead. Now, for other people, it's terrific. Right? Some of the first, so I went to Buffalo with Nick Hoppins to train to do carotid stenting. And at that point in time, we were talking about technology that was available. And so we then said, well, why don't we do some IVUS? We'll take an IVUS catheter around the siphon, see what the vessels looked like. We hadn't known anybody that had done that before. And so it was pretty exciting to do that and to learn what a dissection in the MCA looks like. Does it look the same? How does it handle? How does it feel? So I think all of those sort of things, there will be a group of people that are wildly interested and are interested in spending the time to learn the science, to learn the practice patterns about patients with that specific condition. There will be others that say, "Gee, I'm busy enough. I don't need to. I don't need to do that, and I still provide incredible good care for my colleagues and for my patients." That's a long-winded answer, but that you knew
Well,
it
but it's always good
before
to
I.
hear. Not really, because I mean, I agree with you. It's not for everyone, but again, who decides to do that? As you say, it's a nuanced conversation. There are different levels. It's not just black and white. There are many gradations that
Right.
um, to explore. But you, on the other hand, have been able to work in a wide area, not only on the basic, but also, you've been tremendous on the clinical research, on creating new devices, on leading ACC and SCI and other societies. So you've done so many things in so many different areas. So how were you able to bridge the differences? It's a different skill for doing the research versus doing the cases versus doing the leading the societies. How were you able to match those different areas of different skills, clinical and otherwise?
I think along those ways, you have to make some decisions about how you want to spend your time, and when you can make a. Let's see, sorry, and how you can make a difference for the people that you're working with and the expectations that you have. So I think that what you have to decide of what are the priorities of clinical and administrative issues that should take priority, and there will be a hierarchy of those things. And I think that that's part of spending time getting the biggest picture of a field that you possibly can, knowing areas that you don't necessarily know all about, of which there are about a zillion. Um, Knowing areas that are ripe for changes. It's been very interesting as we think about the development of new technology. Some of the new technology that we're now using has been around for a long time, and we didn't think it worked because that was because we didn't know how to work it or in whom to work it. And so all of a sudden, some of the things look like they're pretty good. And we should test them again, either with as an alternative adjunctive therapy or work at them in a different way. And so some of the older technology are going to be pretty great. We we can't forget the past because it didn't work, because some of the time we just didn't know how to work it. So there are lots of issues with that. I guess the most important thing is to always be asking questions. And so when you go to a meeting and somebody then is presenting a case or doing a case, you look and see, gosh, are there things that could have been asked that they didn't think about how to take care of the patient before or afterwards? Are there some technical things that you can see based upon your experience? They could have tried this. And so I think what we need to do is to keep sort of lists in our mind about opportunities. As part of that, and being in leadership capacities like you are and other people are, to make sure that we then encourage people along to come with new ideas to you so that you can then say, gosh, there is this interesting subject, an interesting approach. I would like you to look at that. We could work together on it. I will help you. I will learn from you. We'll learn together. And that's the wonderful thing about doing the things that we do, that we can take people and bring them along and learn from them at the same time as they're learning from us. And I think that's a home run for patients, for society, for each of us, for the professional organizations that we work with. We just have to be prepared to say, gosh, wouldn't that be neat? Wouldn't that be exciting? How can we do it better? How can we work better together to make a difference?
Wonderful. Now, I still remember you published the first paper on dual injection for CTO. So I still quote it 25 years later. And I still remember how you were handling the emergencies in the cath lab, staying calm, getting things moving. So how do you learn that? How do you learn how to stay calm when things don't go well during the procedure or outside the procedure and keep on moving forward and solving the problem?
I think that is something that there are two parts to that. That is something that is innate in some people, but it's also a learned skill and a learned practice to say, let's step back a minute and rethink things. Now, that can be done in a very short period of time. So perhaps one of the very relevant examples relates to meetings with the FDA and Bram Zuckerman. Being with the FDA in terms of the development of new technology, you learn a lot about how that happens. You would be involved in relatively heated, tough discussions where all of a sudden it looked like everything was going to go to hell. And Bram would say, let's step back a moment and take a moment to consider what this is. And immediately, when you did that, people sort of pulled back a little bit. In the cath lab, you have a short time to do that. I think that's incredibly important. Part of the cath lab, I think, is to, number one, have there be an overall captain. We went through it in the professional societies. We went through a phase where we were doing a lot of live cases, and you were part of those things. One of the concerns that surgeons had, as well as interventional cardiologists and societies had, was should you then be so heavily involved in doing the case that you can't talk about it? That there should be somebody in charge. And so in complex cases, it looked like that and sometimes we can predict if there are going to be problems. It's nice to identify specific roles. Somebody that's going to be able to say, in this case, to your anesthesiologist, would you take care of that? I do all those things that you know how to do, and you can then give me feedback or give us all feedback. But I'm not gonna I'm not gonna take care of the details that you anesthesiology know about. And the same would be true with somebody that is monitoring arterial pressure or ventilatory capacity, those sort of things. You need to have somebody that can say, I need the whole picture of things. this is what we have. This is what either we do know or don't know. And then we have to then make sure that we've decided a strategy that's going to work as best that we can, realizing that nothing is perfect. That's a long-winded thing about the ability to have people work in their specific area and have there then be an overall person in charge that can say, this is how we put it together from the different opinions that we have around the table. Realizing that, number one, we need to make sure that there is order. You cannot have a situation where everybody's talking at the same time. And at some point in time in those emergencies, you have to say, quiet down. We cannot have all of this stuff. It just frazzles us. We want now specific opinions from these specific people about where we are and what we can do. And so some of it, you need to calm the waters before you can then get to shore.
Wonderful. So keeping an order, which is critical, cath lab and otherwise. Now, when it comes to teaching, and again, you've taught so many fellows over many years, can you tell, or could you tell, when you were meeting someone for the first time, are they going to be a good, interventionalist or not as good at? Could you tell? Or was it something that you found out later?
I think there are, I think looking on it, there were three groups of people. One group was that group that weren't going to have it. And you knew that either because of their track record or because of what you observed very early on, and that the mindset wasn't there, and the technical stuff wasn't there, and the thinking about things wasn't there. That doesn't mean they were dumb or stupid or idiots or anything. That would be a group of people that you would still train in basic sort of things, but at the end of their training, you would say, "Gosh, this is you should be thinking about other possibilities for cardiovascular disease, of which there are a zillion." There were a second group that clearly had it. They were, you were able to tell that they had technical aptitude. They were able to think during things, and then they were able to ask good questions. Not so detailed questions that it took the train off the tracks, but they asked the relevant questions, and then you discuss those later. And those people, you were going to be very good. And then there were a third group that was always harder. That was a group that they continued to learn. Both of the groups continued to learn. But there was a group of people that seemed to be a little slower. But they continued to learn, and they then mastered the things. They may never have gotten to the stage of being an incredibly talented operator, but they were a very good operator that was safe and did good stuff. And they continued to learn. And that was we used to see people like that. And they were then incredibly good colleagues. And they provided great services. They weren't necessarily the person that was going to say, boy, I'd like to learn how to do carotids or chronic occlusions or something like that. But they provided incredibly good skills and were very, very capable and very trusted colleagues. Those would have been the three different categories that I would have seen over the course of my career.
Wonderful.
So, you know which category you would have been in.
The slow one, I don't know.
No, give me a break. So, I think
No, but I mean that's a great point. But the question is though, is it like can you get a sense right away, or do people surprise you later on, or vice versa? They look very good early on, but then maybe they get a little too comfortable, too confident, maybe a little too early.
both of those are important. And And I think that latter group is a group that you think that they're really rolling. But some of it has been bravado, and then that can fade. And that's a group of people that you have. And we're always looking at people around us. How are they doing things? Do they do it better? Could they be better? Could they better? Can I learn from them? But you're always then looking to see, as we get further and further out on limbs, how people do when they're out on a limb. And you tell a lot about a person when they're out on a limb. And some of the people out on a limb say, I'm going to come back off of this limb, but I'm not going to get out on another limb again. It's not my deal. I can do other things. And that's a terribly important part for them to understand and for you to understand so that you can talk with them about that. All of those things have to be focused on the individual person that you're talking to, as well as what their needs and desires are. Some people will understand what you're saying. Some people will. It will be something that they've thought about for a while themselves. But they wanted to have, they sort of like to have somebody confirm it in a nice way. And some people, you're going to have to then, from an administrative standpoint, say, gee, this is how I see or you see the future for you in this specific area.
Wonderful.
But I don't want to use the term cowboy, although it's such a nice term. We don't need cowboys. We need people that are keen to lead the field to places that treat patients that we've not been able to treat. We need people to learn how to identify those people and then how to study those people appropriately so that at the end of the time we can say, well, this was a good idea. And we tested it. And we learned enough about, or in our institution, we had enough people to talk to about how we study it so at the end of time we can say, that didn't seem to work. And then you have to say, did it not work because we didn't know how to do it or because it doesn't work? Because there will be some things that don't work.
So you clearly have done this a long way on many pathways and many devices and many techniques as well. But my understanding is that you are still keeping up an open mind and learning new things. So how do you decide to take a break from clinical practice and now start your new adventure with studying again? That's so fascinating and so inspiring. So how did that come to you?
I think that there are a couple of things. Number one, there's having seen people over the course of my career that changed their focus. They became much more energized. I'm going to give you a specific example. There was a man here in Rochester. He was a good conservative, and that's not a bad thing. He was a good conservative physician, and he did a very good job taking care of patients. It was a good clinical job, and you would be well taken care of by him. At some point in time, when I was director of pacing, I got to chatting with him, and I said, well, would that be something of interest for you to consider a change in your practice and learn pacing? He was technically good. He was a good thinker. He hadn't done that before. He said, well, I'll think about that. And so he did that. And it was like overnight, he was a new guy. It was a brand new field for him to study, to become more interested in, and it changed his career, changed his thought pattern, it changed his approach. And all of a sudden, he's a different guy. And so I think when I thought about things that I wanted to do, I wanted to do. I had written poetry for years for myself. Yeah, a couple of them were published, and most of them probably were trash, but I enjoyed doing that. And so I thought it would be very nice to learn a different thing that would still involve creativity, that would involve writing, which I like to write, that would involve talking and learning from people about their stories. This came then from one of the most bothersome, embarrassing, humiliating experiences that was ever part of my career. I was sort of at the peak. I was still doing all the stuff, and is still head of the lab, and was still on a lot of the ACC committees. As part of the ward rotation, I had a ward rotation to take care of general cardiology on the weekend. The fellow that I had was a brilliant young lady, and she was married and had a family. And so I said, I'll take this weekend for you so you can be with your family. Um, Typically, those weekends, you had very elderly people that had comorbid disease that you couldn't do anything about. And so you made rounds on them, and you wrote your antibiotic or whatever it was that you did on rounds. So I did that all weekend. And on Monday, she then came back. And I said, well, how was your weekend? And she said it was just tremendous. She then said, well, how was yours, Dr. Holmes? We were still at she was calling me Dr. Stage. She said, how was yours, Dr. Holmes? And I said, well, it was sort of grim. There were a lot of older people, and I wrote them a script for antibiotics or whatever it was. And she then said, that then was a huge opportunity that you wasted and that you missed out on. I sort of was taken back a little bit. And she said, she always enjoys the weekends. There's not as much pressure. And she has a chance to listen to the patients, to listen to their stories. And they all have stories. You just have to ask them about their stories. And she said, that was a missed opportunity. And I thought about that, and I continue to think about that. Everybody has stories. We just have to bring the stories out. And so the chance of going back to school is learning about new stories that people have to tell over the course of their life, however long or short their life is. And we can learn about their stories and learn new stories for us. And so going back to school for me is learning new stories and exploring new ideas about those things that matter. Pretty
Yeah,
straight.
sounds, obviously it's great for thinking, great for psychologically, but it's a lot of work as well. So how are you able to handle that? You've been working very hard forever, so for you it's nothing. But for other people, they may say, well, retirement is the time to take a break and sit on the couch and relax. How would you answer to these people?
So this semester, I took a full course load. So for the final week, I had two 25-page papers to write. I had a test And then I had a protocol to develop to put on sort of a play about a certain type of scene in environment science in the course of a week. And so it was a hugely great week.
So lots of learning and lots of opportunities that weren't missed.
Mm-hmm. And I did not want to miss that.
Mhm. Now, always remember that you were very exercising heavily and being strong and keeping everything in good shape. Are you still doing that? What kept you? And do you think that was important for the way you feel and the way you work?
Sure. I still try as often as I can to get up at 4:30 and exercise. So I exercise for an hour and a half at that point in time. I either do an elliptical or do weights and all those sort of things. And you get to the point that if you don't do that, you think, boy, I'm really slacking off. Now, there will be times that you slack off. And the next day you think, I just can't continue to slack off like this. Pretty soon my life will be gone and I won't have exercise again. So you continue it. And that's terribly part of it.
Mhm. And that has been going on for a long, long time. And then, do you do anything else to keep you calm or keep you focused, or it's just the work?
Mm. I'm playing the piano and I love the piano. I love the piano. So I play that whenever I can. I have special pieces that I play, and I'm constantly trying to play more and a wider range of pieces, and that's incredibly good. We have where we live in Montana, we have a new grand piano that was, according to the maker of it, it's a piano that's made to play Debussy, and so I play Debussy on that piano, and it's been magic. It's a
Yeah.
but but they're good days, and at the end of the day, you say, "Wow, where did it go? I better get some sleep because I got to get up at 4:30."
And then, how do you actually uh, do you go to bed early? How much do you sleep to keep all the activity going?
I think that I think that there are a couple of things related to that. It's harder this time of year because when the sun goes down, some of the time, some of your interest in things fades. So I would try to get um, I would try to get to bed by 9:30 or 10, and then typically get up at 4 or 4:30,
Wonderful.
and it seems to work. I always wish that I only could sleep 3 hours a night, and I can sometimes do that, but then it's harder to recover from that than it used to.
The loss of nature, I guess. The rest is important. That's for sure. So, David, you've done more than most people would have hoped for to accomplish in several lifetimes, not on once. What are the things that for you have been the most important? What are you most proud of the many, many things that you've accomplished?
My family. I wish that I could grow up to be as bright and as good as my kids are. Pretty straightforward. I would like to be as good as they are.
And for the people who are coming next, or for the next generation, what advice would you have for them? They want to get good in cardiology intervention, they want to fulfill their dreams. What would you tell them is the most important to do that?
Listen to others, dream, and imagine how wonderful it is that you have and how much more wonderful you can make it. Doesn't get much better than this. And then you have young kids come along, and they then become your family too, because we talked about my kids, but I've got a whole bunch of kids that I have taught and raised and watched them grow much better than I am. And that then keeps you going, keeps you young. So you might say, gosh, there's a kid, I think his name is Manus. And he's the sort of kid that you'd like to grow up to be like. And there he is then, talking with you. And a kid like that then makes everything wonderful, because they do all of the things that you'd like them to do and that you'd want to do yourself if you were them, but you're not them. But they then have part of you in them. And that, wow, you're talking about going to sleep and saying, this has been a day well done. There's a kid here that makes all the things that you would ever want him to make, even better. And the world is like that.
Well, I think on behalf of the many kids that you had over the years, I would like to all thank you. And thanks for the teaching you've done before, the teaching you keep on doing right now. And I think that will help a lot of people, including myself, to move on and try to be the best we can, just like you.
The world is safe in your hands, kid. That's all I can say. Kids like you, it's going to be good. It's going to be tremendous. And we're counting on you. Thank you. For you.
Thank
Have a great one.
Thank you for listening to the Sensei podcast.